A 30-year-old woman, an avid cyclist, was enjoying a sunny afternoon ride when a car accident changed everything. The impact threw her from her bike, resulting in multiple injuries, the most serious of which was an open fracture in her right leg. Open fractures, where the bone pierces the skin, are particularly concerning due to the high risk of complications. This case unfortunately proved just how serious these complications can be. After surgery to repair the fracture, the patient began experiencing a cascade of unexpected and life-threatening events. The patient's ordeal is a stark reminder of the complex challenges posed by open fractures. It highlights the importance of understanding both the immediate and long-term risks associated with these injuries. In the following sections, we will delve deeper into the intricacies of this case, exploring the differences between open and closed fractures, the formation of blood clots, and the devastating impact of stroke. Open fractures differ from closed fractures in a critical way: the presence of an open wound. This exposed site becomes a potential gateway for bacteria, significantly increasing the risk of infection. These infections can range from mild to severe, potentially leading to complications like osteomyelitis, a bone infection that can be extremely difficult to treat. The open wound also disrupts the natural healing process, often resulting in delayed bone union. In addition to infection and delayed healing, open fractures also carry an elevated risk of thromboembolic events, such as deep vein thrombosis or DVT. DVT occurs when a blood clot or thrombus forms in a deep vein, usually in the legs. The presence of a fracture, coupled with factors like immobility and tissue damage, creates a perfect storm for clot formation. In this patient's case, a thrombus formed in her popliteal vein, a major vein located behind the knee. This seemingly straightforward injury had taken a dangerous turn. While closed fractures don't present the same risk of infection as open fractures, they are not without their own set of complications. These can include compartment syndrome, a serious condition that occurs when pressure builds up inside a muscle compartment, restricting blood flow to muscles and nerves. Left untreated, compartment syndrome can lead to permanent muscle damage. Fat embolism syndrome is another rare but life-threatening complication that occurs when fat droplets from the bone marrow leak into the bloodstream and travel to the lungs, brain, or other organs. Malunion refers to a fracture that heals in an abnormal position, potentially leading to deformity or functional impairment. Non-union occurs when a fracture fails to heal properly, often requiring additional surgery. Though closed fractures generally have a lower risk of complications compared to open fractures, it's crucial to remember that each fracture is unique. The severity, location, and overall health of the individual all play a role in determining the likelihood and type of complications. The formation of a thrombus in the patient's popliteal vein was not a random event. It was the culmination of a cascade of events triggered by the open fracture and subsequent surgery. Three primary factors contributed to this endothelial injury: venous stasis and hypercoagulability. The fracture itself, along with the surgical procedure, caused damage to the inner lining of the popliteal vein, known as the endothelium. This damage disrupts the smooth flow of blood, creating a rough surface where platelets and fibrin can adhere, initiating clot formation. Prolonged immobility after surgery, a common practice in fracture management, leads to reduced blood flow in the legs, a condition known as venous stasis. This sluggish blood flow allows clotting factors to accumulate, further increasing the risk of thrombus formation. Trauma and surgery tip the body's coagulation system towards a hypercoagulable state, meaning the blood is more likely to clot. This natural response is meant to prevent excessive bleeding but can backfire in the venous system, leading to DVT. This triad of endothelial injury, venous stasis, and hypercoagulability is known as Virchow's triad and is a cornerstone of understanding venous thrombosis. Recognizing these risk factors is essential for implementing preventive measures in patients who are at an elevated risk. Section 5: Stroke signs. When the brain sends warning signals. Days after her surgery, the patient began experiencing a constellation of neurological symptoms that raised red flags for a potential stroke. These symptoms included sudden onset of weakness. She felt a profound weakness on one side of her body, making it difficult to move her arm and leg. Her speech became garbled and difficult to understand. One side of her face felt numb and droopy. She experienced blurred vision and difficulty seeing in one eye. These neurological deficits pointed to a disruption of blood flow to a specific region of her brain, a hallmark of stroke. Given her recent surgery and the presence of a popliteal vein thrombosis, the medical team suspected a paradoxical embolism. This rare but serious complication occurs when a venous clot, such as the one in her leg, travels to the arterial circulation, bypassing the lungs and lodges in an artery supplying the brain. Section 6. Hidden pathways, congenital anomalies and embolism risk. The suspicion of a paradoxical embolism raised another question. How did a clot from the venous system cross over to the arterial circulation? The answer likely lies in the presence of a congenital heart defect that went undetected for 3 decades. Several cardiac anomalies can create a passageway between the right and left sides of the heart, allowing clots to bypass the lungs and enter the systemic circulation. These include patent foramen ovale, or PFO. This is a small opening between the atria, the upper chambers of the heart, that typically closes after birth. In some individuals, it remains open, creating a potential pathway for emboli, atrial septal defect, or ASD. This is a hole in the septum, the wall that separates the atria, allowing blood to flow between the chambers. Pulmonary arteriovenous malformation, or PVM. This abnormal connection between an artery and a vein in the lungs can allow clots to bypass the normal filtering mechanism of the lungs. While these congenital defects are often asymptomatic, they pose a significant risk for paradoxical embolism in the setting of deep vein thrombosis. It's crucial to investigate for these anomalies in patients who present with stroke and a history of DVT. Section 7. A path forward. Managing stroke, anticoagulation, and congenital defects. The patient's case presented a complex medical puzzle requiring a multi-pronged management approach that addressed both the immediate emergency and the underlying causes. The initial focus was on stabilizing her condition and mitigating the effects of the stroke. This included stroke care. She received specialized stroke care in a dedicated stroke unit with a focus on supportive measures such as oxygen therapy and blood pressure management. Anticoagulation therapy. Immediate anticoagulation therapy was initiated to prevent further clot formation and potentially dissolve the existing clot. This typically involves intravenous heparin followed by oral anticoagulants, such as warfarin or newer direct-acting oral anticoagulants, or DOACs. Diagnostic imaging. A brain MRI confirmed the diagnosis of stroke, revealing the location and extent of the damage. An echocardiogram with bubble study, a specialized ultrasound of the heart, helped visualize the PFO, confirming the suspected route of paradoxical embolism. Long-term management focuses on stroke rehabilitation. Depending on the severity of the stroke, she may require extensive rehabilitation, including physical therapy, occupational therapy, and speech therapy to regain lost function and improve her quality of life. Long-term anticoagulation. The duration of anticoagulation therapy varies depending on the individual's risk factors and the presence of underlying conditions. In this case, given the paradoxical embolism and congenital heart defect, long-term anticoagulation is likely necessary to prevent future events. PFO closure of the PFO may be considered to reduce the risk of future paradoxical embolism. This minimally invasive procedure involves inserting a device through a catheter in the groin that seals the opening in the heart. Section 8. The importance of early detection and comprehensive care. This case underscores the critical importance of early detection, prompt treatment, and a thorough understanding of both the common and rare complications associated with open fractures. It also highlights the need for comprehensive care that addresses not only the immediate injury, but also any underlying conditions that may increase the risk of complications. Timely diagnosis and treatment of DVT are paramount in preventing serious complications like pulmonary embolism, or PE, and paradoxical embolism. Early signs of DVT, such as leg pain, swelling, and tenderness, should not be ignored. Physicians should maintain a high index of suspicion for DVT in patients with fractures, particularly open fractures, and initiate appropriate diagnostic tests, such as ultrasound, without delay. Furthermore, a detailed medical history, including any family history of clotting disorders or congenital heart defects, can provide valuable clues. In this case, knowing about a family history of PFO or previous DVT episodes could have prompted earlier screening and potentially prevented this devastating event. Section 9. Looking ahead, rehabilitation and long-term prognosis. The road to recovery after a stroke can be long and challenging, requiring patience, perseverance, and a strong support system. The extent of recovery varies greatly depending on the severity of the stroke and the areas of the brain affected. Some individuals make remarkable recoveries, regaining most or all of their lost function, while others experience lasting deficits that require ongoing care and support. The patient's young age and overall good health prior to the accident work in her favor. With comprehensive rehabilitation and unwavering determination, she has the potential to make significant strides in her recovery. However, it's essential to acknowledge that the journey may be marked by setbacks and challenges. Ongoing support from healthcare professionals, family and friends is crucial to navigate these challenges and celebrate victories, both big and small. This case serves as a potent reminder of the interconnectedness of the human body and the far-reaching consequences of seemingly isolated injuries. It underscores the importance of a holistic approach to patient care, one that considers not just the broken bone but the entire individual and their unique set of circumstances. Through early detection, proactive management, and compassionate care, we can strive to minimize the impact of these life-altering events and empower patients on their road to recovery.